Jean-Michel, c'est un grand plaisir d'être ici à Paris, face à face avec mon collègue. Maintenant, je continue en anglais. So, but it is really a great pleasure.
Next time it'll be in French.
All right. I actually have the easy part today because I'm going to talk about what we know about drugs for highly treatment-experienced patients. The next talk by Anna Maria Giretti is going to be the harder talk, how to use these drugs in treating the experienced patient. So with that, let me move ahead. Here are my disclosures. So, to take us back several years, the first real effort at cobbling together effective, potent regimens for highly experienced patients was, appropriately enough, the TRIO study, because it was a study done here in France, which combined boosted darunavir, then a novel next-generation protease inhibitor, with etravirine, a second-generation non-nucleoside reverse transcriptase inhibitor, and raltegravir, the first of the integrase strand transfer inhibitors, and showed that in individuals who up until that point had been really barely managing on highly complex regimens that often included the injectable enfuvirtide, that they could take these patients, put them on this 3-drug oral regimen, and achieve and maintain viral suppression in approximately 90%. And this was work by Yazd and Pana. Let me see if I can advance here. And then a few years later, the AIDS Clinical Trials Group did a study called the Options Study that Rich Haubrick and Karen Tashima co-led through the AIDS Clinical Trials Group, showing that if you could put together a regimen that contained at least 2 active drugs, it wasn't really necessary to include the nucleoside reverse transcriptase inhibitors, the NRTIs, any longer, because there really was no difference in outcome in those participants, as you can see in this slide here. And then the Viking Study, which was the first trial with dolutegravir, looked at 2 different dosages of dolutegravir, either once daily or twice daily, in people who had failed on raltegravir and had different levels of resistance to raltegravir and therefore cross-resistance to dolutegravir. And what the study showed, and I guess I can't easily point here, but what you can see is that there was a larger proportion, about 75% of the participants were able to achieve virologic suppression at week 24 to less than 50 copies if they were on the twice-daily dose, compared to just 41% on the once-daily dose. And this is the reason why dolutegravir is recommended twice daily for integrase inhibitor experienced patients who require a further regimen. But there is a caveat to those data, and this was not a randomized study, so these 2 arms were done sequentially, not contemporaneously. And it turns out that if you look at the distribution of the triangles and the squares here, the triangles represent the participants who received once daily dolutegravir, and the solid squares, those who were on the twice daily regimen. And the level of resistance to dolutegravir and the number of mutations was higher in the once daily group than in the twice daily group. So although twice daily remains the recommendation, I'd have to say that the evidence basis for that recommendation is not the most robust evidence that we have. Now, things took a major turn after those studies, because it became apparent that in order to have a regimen that was effective, you obviously needed to put together many drugs, and you really didn't want to expose people to just a single new drug for any length of time, nor would you want to keep people on a control arm for any length of time. And even in the previous era where there were such randomized trials, people rapidly failed in the control arm and crossed over to the active arm. So there wasn't even a long enough time to legitimately compare the safety of the regimen. So recognizing this, the FDA came up with a novel study design, which has been used for all the new drugs that have come subsequently and will apply for the studies that I discuss going forward. And that is to have a very brief period of virtual monotherapy where participants who have limited treatment options are randomized to either stay on that regimen and add placebo, or stay on their failing regimen and add the new drug, where the primary endpoint is either 1 or 2 weeks after the start of the additional new drug, and the endpoint is change in virus load. And these can count as phase 3 trials. Then everybody gets an opportunity to optimize their background regimen, and those in the placebo arm add the novel agent. So going forward, after just 7 or 14 days, everybody is on the new regimen, and then the secondary endpoint becomes the proportion of individuals who achieve full viral suppression as well as overall safety and tolerability. And this design was really intended, again, to minimize the risk to participants of developing resistance to the novel regimen or to burning through their only remaining drugs in a background regimen. And the first of the drugs that use this design is ibilizumab. Ibilizumab is a humanized murine monoclonal antibody that belongs to IgG subtype 4. It recognizes a unique epitope in domain 2 of CD4, and it inhibits post-binding entry of HIV. The precise mechanism by which this happens is not entirely clear. There's obviously some steric hindrance involved because it doesn't block HIV from binding CD4, but it then prevents subsequent rearrangements and interaction with the co-receptor and the progression through the fusion process. Years ago now, hard to believe, nearly 20 years ago, we did the phase 1 study of ibilizumab, which showed rapid declines in virus load with about a 1.3 or 1.4 log decline achieved after 14 days at the highest dose level. This was accompanied by similarly rapid increases in CD4 cell count. This drug then struggled through a phase 1b study plus an initial phase 2 trial, and then nothing happened for more than a decade until finally this phase 3 design led by Brenda Imu was done. And here you see this design based on that FDA prototype, where there was here actually no placebo group. Here, all of the participants received ibilizumab. There was an observation period. First, they had screening, and then a week-long observation period to see just how stable was their virus load and what change in virus load would occur as part of natural day-to-day variation, comparing day 0 to day 7. At day 7, everybody got a loading dose, and then they had a 7-day functional monotherapy period called functional monotherapy because the only new drug they had was ibilizumab, and then at day 14, optimized the background regimen, and then continued getting every other week infusions of ibilizumab at a lower dose out through week 23. So there were all of 40 participants in this phase 3 study, which is probably the world's smallest phase 3 trial, at least in the HIV field. And what you can see here is that, and the primary endpoint, the target was a half-log decrease. So that's a pretty modest target compared to what we're used to. Only a single individual during the control period, that day 0 to 7 period, had a half-log change in virus load. Perhaps that was because they started taking their drugs better or just natural variation. But 83% or 33 of the participants achieved this half-log decline after just a week post-dosing of ibilizumab. 60% achieved a 1-log decline, with the average decline from day 7 to day 14 being just over a log. And those, not surprisingly, were highly significant changes, and so the drug met its primary endpoint. And that's the basis for the approval of ibilizumab. Now, with subsequent follow-up and additional analysis, what you can see is that in the total ITT population, here now looking at the changes out to week 24, about 40% achieved less than 50 copies, and roughly 50% achieved less than 200 copies. That was much more likely to occur for people who had higher CD4 counts, greater than 50 cells per microliter at baseline. And you can also see that the change in virus load, the decrease in virus load, depended as well on baseline immunologic status, and the CD4 count increases similarly dependent on how advanced the participants were. Those who had less than 50 cells at entry showed just a mere 25-cell increase, whereas those who had higher CD4 counts at baseline achieved about a 75-cell increase by the end of the study. There were a number of adverse events, but there were no really particularly significant events that would be other than what you might expect in this a group of people with advanced disease who were receiving other agents. Only 9 serious adverse events, which I guess was close to a quarter of the population, and there was rash that was seen in 5 of the participants. Now, one can see resistance to ibilizumab. Now, this is surprising, perhaps, because ibilizumab targets a host cell protein, CD4. But in the phase 1b study already, and in the phase 2 study, it was shown, the earlier phase 2 study was shown that you can see shifts in susceptibility. And just as we used to see for Maraviroc, if you can remember back, instead of seeing a shift in the IC50, you see a decrease in the maximum percent inhibition. So you see these curves are not so much shifted to the right as they are blunted. The yellow or golden color curves there that don't get much above 75% in the patients from whom resistant virus was obtained, and Monogram did all of this work, and you can see they've mapped changes in envelope to position 460 and 464, which when present together reduced the maximum percent inhibition to just around 30%. Exactly how this interaction works to create resistance is still not fully understood. The second agent, which is also a kind of entry inhibitor, is fostemsavir. Fostemsavir is a prodrug for temsavir, the active drug, and this is a first-in-class attachment inhibitor. Now, although it is called an attachment inhibitor, in fact, there's some controversy about the precise mechanism. At high doses, temsavir does indeed block the interaction of GP120 with CD4. But at doses that are achievable in people, it probably functions by locking envelope into a particular conformation that prevents it from interacting then with, undergoing the conformational changes necessary to interact with CCR5. Thank Don Cohen for pointing this out to me as we were writing a chapter on antiviral therapy. This drug is active against viruses regardless of their tropism, so R5, X4, and dual tropic viruses, and it's synergistic or additive in combination with antiretroviral drugs from other classes. Like the design that I showed you for ibilizumab, the BRIGHT trial, which was the phase 3 trial of fostemsavir led by Mike Kozal, used this design of having a very short time to the primary endpoint based on percent reduction or log reduction in virus load, and then an open label phase. This study was somewhat different from the study we saw for ibilizumab because here they had 2 cohorts. There was a randomized cohort for participants who had 1 or 2 fully active drugs that could be used in a background regimen, and they were randomized 3 to 1 for this week-long period of getting either blinded fostemsavir or placebo on top of their failing regimen. Then everybody optimized their background regimen and received fostemsavir. The cohort that had no remaining drugs was given the opportunity to receive open-label fostemsavir from the beginning. This was a kind of a salvage therapy arm done as part of the phase 3 trial. But the analysis is based on the blinded component, or the randomized cohort. What you see on this slide here on the left, the proportion of participants who achieved less than 40 copies or less than 200 copies over the 48 weeks of the study. You can see that just over 60% had full suppression and about 85% were able to achieve less than 200 copies. That success rate was significantly lower in the non-randomized cohort, just about 50% achieving those virologic endpoints. The primary endpoint was the difference in log reduction in virus load at between day 1 and day 8. There was about a 0.15 log reduction in the placebo group and nearly a 0.8 log reduction in the fostemsavir group. No big surprise here that this result is statistically significant, and again, this is the basis for the approval of fostemsavir, this very modest difference in virus load, which is essentially about a 0.6 log difference. There were significant increases in the CD4 count in the randomized cohort, much greater than in the non-randomized cohort, so that by the end of 48 weeks, there was nearly a 140-cell increase. And it's notable that the increase in CD4 cells continues, even though peak viral suppression was achieved much earlier on. Whether there's a mechanistic basis for this or whether it's simply the slow second phase of CD4 increase that we remember from the first triple drug therapy trials is still being debated. Looking at adverse events, there were, again, about a quarter of the participants in the randomized cohort had grade 3 or 4 adverse events, but only 5% of those led to discontinuation. Many of the serious adverse events were Class C AIDS-defining events. Only 3% were considered drug-related. There were deaths, unfortunately, in both the randomized and non-randomized cohorts. And the most common adverse events were diarrhea and nausea. The last drug that I'll speak about is Lena Capovir. This is a completely novel drug with a novel mechanism of action. This is a capsid inhibitor, and this drug has been important not just because of its activity and its potential for use in both therapeutics and in prevention, but because it's also taught us a great deal about the biology of the HIV capsid. The capsid, of course, is the core particle of the virion made up of the P24 protein, and it turns out that capsid is essential for importation of the pre-integration complex into the nucleus. It helps the completely reverse transcribed double-stranded DNA enter into the nucleus through the nuclear pore and then disassembles, allowing for integration to occur. And then, of course, the capsid has to be assembled at the later stages of the virus life cycle. Lena Capovir interferes with 3 different steps in the virus life cycle. It interferes with nuclear importation, it interferes with capsid assembly, and with virus assembly and release. This paper from Nature from 2 years ago shows a number of important aspects of Lena Capovir. First, in the top figure here, you see the results of the phase 1/2 study, a dose-ranging study that showed how potent this agent was, because even at doses of 20 and 50 milligrams over 9 days, about a 1.5 log reduction was achieved, and at a 150 milligram dose, close to a 2 log reduction was achieved. But as you see in the bottom panels, with passage in the presence of drug in vitro, one can select for mutations that reduce susceptibility to Lena Capovir. And a number of mutations have emerged in different passage experiments, but one of the ones that shows up commonly is a mutation at position 67, the Q67H substitution. This is sometimes seen with other mutations, and although it may be hard to read here on the screen, one of the mutations that appeared as well was a substitution at position 66, as well as one at position 70. And these will turn out to be important when we look at the data from the human clinical trials. So the Capella study design may look very similar to you from what I described for the fostemsavir study. Here again, there is a randomized cohort and a non-randomized cohort. Participants had to be viremic. They had to have resistance to at least 2 agents from 3 of the 4 main classes of ARVs, so nukes, non-nukes, protease inhibitors, and integrase inhibitors. They had to have 2 or fewer fully active agents available, otherwise they wouldn't have a reason to be in the trial. And those in the randomized cohort were assigned in a double-blind manner to either continue on their failing regimen and receive placebo or receive oral Lena Capovir, and this was for 14 days, after which all the participants optimized their background regimen, Those who were in the oral lenacapavir arm then began receiving subcutaneous lenacapavir, which, because it is long-acting, was dosed every 6 months. So this is an amazing advance in terms of the ability to give long-acting therapy for highly treatment-experienced patients. Those who were in the placebo group first had to get 14 days of oral dosing to exclude presence of any hypersensitivity reactions that might occur, and then transitioned to the same every 6-month subcutaneous dosing. The non-randomized cohort, which essentially began filling after the randomized cohort was fully enrolled, was an equal number of participants who simply received oral lenacapavir, then transitioned to subcutaneous lenacapavir with an optimized background regimen. And again, as with the fostemsavir study, these participants don't count in the primary analysis of the trial. The slide shows the primary endpoint, which was the percent achieving a virus load decline of greater than half a log. So 88% of the people in the lenacapavir arm did so, as opposed to only 17%, or 2 out of 12 participants in the placebo arm. And not surprisingly, that's a highly statistically significant difference, and so the drug met the primary endpoint. If we look at the log reduction, you can see that nearly a 2-log reduction was achieved by adding lenacapavir to the failing background regimen in the randomized cohort, compared to a 0.3-log decline in the placebo participants. And again, that was highly statistically significant. Now, if we look at resistance, 11 of the 36 participants in the randomized cohort met criteria for resistance testing, meaning they had protocol-defined virologic failure and a sufficient amount of virus in order to perform resistance testing. And you can see that 7 of them had no evidence of emergent resistance, but 4 did, and each of them had somewhat different mutations. These are not mutually exclusive, but 4 of the participants had this M66I mutation that I pointed out before. So even though this mutation turned up relatively uncommonly with in vitro passage, it seemed to be the most common mutation, at least in this group of participants. The Q67H mutation, which most commonly emerged in vitro, was seen in 1 participant, as was or were changes at codon 70 and at codon 74. All 4 participants with emergent lenacapavir resistance remained on lenacapavir. 3 of them eventually resuppressed at a later visit, 2 without any change in the regimen, and 1 with a change in the optimized background regimen. And then 1 participant with no fully active agents never resuppressed, unfortunately, and continued with a high level of resistance. None of the participants developed additional resistance to the agents in the optimized background regimen. So to conclude, the goal of treating patients with complex antiretroviral treatment histories is to achieve, once again, full virologic suppression. A new regimen can include 2 fully active drugs if at least one of those drugs has a high resistance barrier, such as dolutegravir or a boosted PI. But new drugs with novel mechanisms of action, such as the ones that I've reviewed with you this afternoon, increase our options for constructing antiretroviral therapy regimens that contain 2 or more active drugs and increase the chances of longer-term success for our patients. So with that, I'll stop, and I'm happy to take questions now or during our discussion period.
I think